You're still watching Good Morning Nigeria on the network service of the Nigerian Television Authority. As a prompt for our conversation on healthcare for older persons in Nigeria, let's listen to this background put together by Abdusalam Jibril.
An African proverb states that when an old man dies, a library burns to the ground. This connotes that older people have much to teach about life, hence the need to adequately cater for them. Birth, childhood, adolescence, adulthood, and old age are the most crucial stages in a man's life. As each level passes, the physical strength deteriorates as well as the mental stability lessens. Experts note that traditionally, the responsibility of providing long-term care and support for older persons is the duty of the families. However, modernization, urbanization, and increased participation of women in the workforce have led to a reduction in available family primary caregivers for older people. Consequently, many families are either unable or unavailable to provide long-term care and support for older people. Older persons also face certain challenges that include poverty due to loss or reduction of earning power, vulnerability to chronic diseases, poor healthcare delivery systems, financial burdens, as well as abuse, discrimination, and neglect, which is gaining attention as a major social problem. Towards ameliorating the plight of older persons in the country, the National Senior Citizen Center has signed a memorandum of understanding with the National Primary Healthcare Development Agency geared towards achieving integrated care for older persons. A first of its kind, some experts note that the robust and inclusive healthcare delivery model for senior citizens in Nigeria is aimed at boosting healthcare delivery for senior citizens in Nigeria. How effective will the policy's implementation be towards boosting healthcare delivery for older persons? Aside healthcare, what other policies are available or in the works that caters for senior citizens in Nigeria? Guests on the program will be speaking to issues on healthcare for older persons in Nigeria shortly.
All right, Abdul Salam Jibril bringing us that background report to kick off our conversation. And I'm glad to tell you that all our guests are all seated, some in the studio and some joining us via Zoom. Let me begin my introductions by welcoming the Dr. Imem Omokaro. She's a familiar face. She's the Director General, National Senior Citizens Center, and the lady who is doing all the magic for the senior, of course, persons in Nigeria. Glad to have you with us, madam.
Thank you so much. Always glad to be here.
Dr. Chris Elemowa is Acting Director, Community Health Services at the National Primary Healthcare Development Agency, NPHCDA, and he will be giving us all the explanations. Thank you for joining us.
Thank you very much, ma. I'm glad to be here.
All right. Also here with us in the studios is Hajia Hawa Umar Jibrin, founder of the POS Old People's Home here in Abuja. Hajia Hawa, pleasure to have you with us this morning.
Thank you for having me. Good morning, Nigeria.
Okay, and joining us via Zoom from Zamfara is Dr. Tukoro Ismail. He's a member of the Forum of Executive Secretaries of State Primary Healthcare Development Agencies. And of course, that's because he occupies that same position in Zamfara. Dr. Ismail, we are glad to have you this morning.
Thank you for having me. Thank you very much.
All right. The background report by our correspondent is sufficiently detailed as to highlight what some of the issues are with senior citizens and care and attention for those category of Nigerians. So, Dr. M.M. Omokaro, Let's have your opening comments on why your center has considered the MOU as a viable alternative to the current state and status and care for older persons.
Thank you so much for having me. I want to say first and foremost that this is happening because a policy and a legal framework has already been set. So we have a policy on aging, and of course we have the National Senior Citizen Center Act that established the agency. So now this is within that framework and within the mandate of the National Senior Citizen Center. And of course, the activities prescribed by the Act, which is that we should identify the needs of senior citizens and should cater for those needs. And on the list of the needs, and of course, which is everybody knows, is health and well-being. Of course, you also have social programs for the vulnerable. You have livelihoods, opportunities, work schemes to engage older persons to continue to earn income or supplement their income. You also have recreation, you have sports, and then of course you have research and building data system, having records of older persons, and then building senior centers where they can go and cut loneliness and cut aloneness, and then just fellowship with their likes and intergenerational programs that we are creating so that they can continue to live happy, secured, dignified, and have every opportunity to continue to upskill, have the trainings, and then have every opportunity to continue to contribute. And where their functional capacities begin to decline, of course, they're entitled to comprehensive care with dignity. So what prompted us was that, of course, we know that already there are systems and MDAs that exist with these statutory mandates. Unfortunately, over the years, they had left out older people. So basically, it was for us to map who are those agencies, which agencies, and what are those statutory mandates that intersect with our own statutory mandates. And that we can go and map all the programs that they have and see what is appropriate for older people and see where they left out older people, and then sit with them in a technical group, to sieve out all those things that pertain to older people, one, as a matter of rights, and two, to also look at the extremes. Because when you talk about development goals and you talk about the targets, what you do is hold it up to the human right lens. Is everybody a right holder? So is everybody entitled to inclusion? And then after that, you hold it up across the life course, like you should rightly. So from, pregnancy to later life. So who has fallen off? So what prompted us to, of course, to go to the National Primary Healthcare Development Agency, because they have the statutory mandate for primary health to lay out the policy, they have implementation planning, and they have all the mechanism and the structures that can penetrate to the very hard to reach places. And 70% of our older persons live in these places and they are vulnerable. So that is what took us to them. And truly, we forged a very formidable partnership, even with the executive secretaries.
All right, DJ, thank you. And if I may, I'd like to say that I said this to you earlier on. I think so far what you do, I like what you do, particularly the edition where you took the senior citizens on a train ride, I think from Lagos to one of the southwestern states. I think I love what you do so far. I like to.
I must say that was even organized by private sector. So we also are incorporating the private sector.
I like to commend that. But let me take my question, and that's where I want to begin. With Hajia Hawa Omar Jibrin. You're the founder of Pause Old People's Home, and I'm just wondering why the name Pause, but never mind. So this is an institution. It's something different, from what we used to know traditionally, where you cater for your persons at home within their communities and all that. Can you share with us what you have to deal with? That's one. And then what are the peculiar needs? Because we have said, yes, medical health, yes, mobility, but from your experience, it would be good for us to know what are some of those needs, that you are dealing with also.
Thank you. The word pause came as a result of when you work hard in life, you get to a point where you need to slow down. So you need to pause. And when you are pausing, you need to rest. You need to enjoy. And that is why we came up with the name, the Pause Old People's Home. We mooted the idea 2018 because looking around, we discovered children are no longer there for their parents. The community has abandoned that neighborhood principle where you are your neighbor's keeper and your brother's keeper. And we said, particularly here in the north, where people are not really, attuned to the idea of old people's home, we made up our mind first to go on advocacy to let them know no old person deserves to be abandoned. No old person deserves to suffer. The fact that you are old doesn't mean you are condemned. You are still useful. We want them around. They are custodians of our history. They are also people that pray and God answers their prayer in time because they have done so much and they know what it is that we need. And they can also be a source of protection. We checked and we discovered that a lot of people, when you say you want to keep them in the home, they say no. We can't throw our older people in the home because they will kill them or they will do something bad to them. But we came up with the idea of going around to the hospitals, to the emirs, palaces, to all the other communities around the federal capital to let them know that we want to take care of them. And in taking care of them, we could also come to the community to take care of them. They don't all have to be in the home. And we started building confidence in them. By so doing, what we do from time to time, we take them out, take them to the Millennium Park, take them to other places where they will get fresh air. We play with them. They feed. We also do for them what we need to do and take them back to their community. And with time, they have now understood that older persons, someone somewhere wants to take care of them. And thank God the National Senior Citizen Center too has also been created. I think with this, the awareness will be wider. Senior citizens in the rural areas, because the population is greatly in the rural areas, once they are mostly an informal sector category of people. They didn't work in the government sector. Then some of them, they were traders, they were farmers. After the age, all they need to do is sit back at home and they just feed them with whatever they need to feed them, not minding what is their health situation, because some of them, they even grow and die without knowing they have ever had any health challenge. So when we started, we made it a point where we call them and bring doctors to check. And lo and behold, we have found that a lot of them have some of these ailments like diabetes, hypertension, and ulcer. And we decided that because of this, we shall do the checks from time to time to make them aware of their health challenges. And we can also take them out to the hospitals where they need to go to the hospitals to get drugs, and we monitor to see that they take these drugs according to prescription. We have also realized that some of them go blind, not because they should go blind, but because when they started having the problem, they did nothing about it. It now graduated into a serious problem, and some of them can't see anymore because of that. So we decided to go to Shandai, Tulsi Shandai, the hospital, the Indian hospital, and we made them to understand that we have people and we want them to help. And they did it pro bono. We took them there. Some of them underwent surgery, some of them got drugs, some of them got glasses. And this is how we are able to bring out some of these challenges. Some of them have arthritis. They stay, they don't even come out. For those who cannot even move, sometimes we give them wheelchair so that they can move from point A to point B. Otherwise, they are meant to stay in the house without real proper care. And some of them, because of that, they die of loneliness. And that is what we are trying to avoid. No elderly person should die of loneliness. Every elderly person deserves to be taken care of. Every elderly person deserves to be happy, no matter where you are, whether you are in the city or you are in the rural area. And that is what brought about this, the Pause Old People's Home. Some of them will be in the home, but some of them will be in their communities. And when wherever they are in their communities, we go there to see how they are doing. Right now, it's Abuja. We have not gone anywhere beyond Abuja, but we are hoping as the time goes on, we are praying that other people will key into this program. They will look at this NGO and also replicate things wherever they are. With the National Senior Citizen Center around, we know that whatever our needs are, we can run to them, we can tell them, they can also lend a helping hand to us.
All right. Thank you very much, Hajia Hawa, for the comments that you have made. Let's bring in Dr. Chris Elemuwa. Dr. Chris Elemuwa is the National Primary Healthcare Development Agency excited about the MOU that you've signed with the NSCC? And if you are excited, why?
Well, thank you very much, sir. We're so excited. My Chief Executive, Dr. Faiz Ashwaib, is so passionate about the care for the elderly too. You know, when we discussed, when the DG came to us and he directed me to, please, he wants me to pay attention to this, you know, and anytime we present an issue on that, it's please deal with it immediately. Yeah, because we believe that everybody will get old one day. We all have elderly parents, you know, and these are men and women that have worked hard in their lives. These are people that have strived to make us grow and become what we are today. We didn't just emanate just direct from heaven. I mean, we passed through them, and then they mentored us. They grew. They fed us. They nurtured us. Yes, so they should be cared for. And why we're passionate is that, one, we have the structure. National Primary Health Care have the structure, have the faculty, like you rightly said at the time, or you said, we have over 40,000 PSCs, you know, across the country, and we have human resources across. Though we still need to reorientate them towards care for the elderly, because with this MOU and with this engagement, with this collaboration with the National Senior Citizen Center, it's like a call to action. It's like stimulating us to action that this is an area we really need to pay attention to. And we're working hard towards that. These are one of the next steps we agreed during after our meeting last month. And we're on course. We also realize that it's about over, like the DG said, to over 70% of people stay in the communities. And we also know how the communities are. So, and if there's no enough care there, then one can imagine how the lives of the older persons will be. Most times, retired ones, like me and you, who one day retire, and we might go to the community. So if there's no appropriate, adequate care there, you know, you can imagine how our lives will be. So that's why we're so passionate and so excited for this strong collaboration.
Okay, thank you. Thank you very much, Dr. Chris Elemuwa. I take my question to Dr. Tukur Ismail, who's joining us via Zoom from Zamfara State. Dr. Ismail, we cannot see your face. It's a bit dark. I do hope you will lighten up your, so we can see your face clearly. Are you equally excited about this MOU? And if you are, I'd like you to tell us what is the cause of the excitement?
Okay, thank you very much. Like my boss has really said, we are highly excited to be part of this stakeholders engagement. The fact being that the care for the elderly is now on the front burner at international levels. And so I'm happy that Nigeria and all the states have aligned to ensuring that we achieve this goal of care for the elderly. And this had already been in the National Strategic Health Development Plan, in which a lot of plans have been developed to ensure that we implement this program. You see, the fact that we're having a larger percentage of this elderly population in the rural areas, and like that's been mentioned earlier, that we have a very broad base of opportunities at the state, local government, ward, and settlement level to implement activities like this. So all we needed to do is to integrate the service across and within the packages, because it has been said that healthcare is a continuum. So we don't have to stop at maybe the women and children at that levels, but as life goes on, we ensure that we also cover the elderly. So this is the level at which the National Primary Health Care, under the leadership of the executive director, gave us the mandate, haven't signed the MOU, that we should develop a strategy that we are going to implement these activities. And already, like I've said, we have an existing structures that we are going to leverage on to ensure that we implement these activities.
Dr. Ismail, thank you very much. I was going to ask you a question, but we're going to give you some time to put more light on your face so that the silhouette effect is diminished considerably. Our viewers would like to see you and then, of course, hear from you. We'll come back to you in the course of this conversation. Back to the studios. Dr. M.M. Omokao. Well, let us know from your experience, your center's surveys and other experiences, what we are now seeking to either lump together with primary healthcare or share with the primary healthcare. How do old people today access healthcare? What is the quality of the healthcare that they access today, and what do we want to get from the primary healthcare access route that you have now chosen?
I want to say first and foremost that for any healthcare to address the needs of older persons, it really has to identify those needs. And so for older persons to be able to access primary healthcare, it means that that primary care has to first and foremost be functional, and then it has to be inclusive. And when we talk about inclusivity in primary healthcare, it means that that geriatric population that has, needs that, the challenges that come, that are age specific. So the assessment of those challenges has to be integrated in primary healthcare assessment system. So for an older person to approach a primary healthcare facility, and there is no such provisions, so you just see this older person and you treat that older person as if it were a pediatric. So it means that you are not providing that assessment. So when it comes to promotion, it comes to preventive, because of course you know that this population category, are prone to disease burdens and prone to chronic situation. And then the essence of primary care is to promote that healthy aging. In other words, care literacy. Let them know what they are like, what is likely to befall them should they continue in this direction. So care literacy, so which is preventive. Primary healthcare has to do that, and which means you have to have access to the older people, not just also only to sit in the primary care facility, but to find a vehicle to be able to advocate, to be able to sensitize, to be able to teach and promote, which means there has to be manual on promotive and preventive care for older people, specific to older people. And then, of course, also, there has to be, like I said, age-friendly environments. There are environments that are age-friendly. There are environments that the older person will not even want to approach. And first, it starts with attitude. Because that is the stereotype and the prejudices that we must fight together. Because an older person wants to go to a primary care facility and they say, Mama, you are old now. And people are praying for that old woman to die because they see that old person as a burden. So basically now services to older persons, especially healthcare services, are not seen as an investment to promote the functional capacity so that they continue to maintain that functional ability and continue to live with vitality and to contribute. Healthcare facility and investment in care for older persons are mostly seen as cost and a burden, even sometimes from within family. Why are we spending so much on this old person when this money could do this and do this and do that? So if we have a functional primary care, so what we desire is first to see that it's functional, two, to see that it's inclusive, which means that everything that is appropriate to care for that older person, that is age specific to that older person, is integrated, like geriatric assessment. And then, of course, this will mean rejigging the curriculum, because the curriculum that exists now, like we saw, because I told you we mapped, is to train in maternal and child, that other extreme of vulnerability. But this extreme of vulnerability really is not too much reflected in the curriculum, which means we have to work together to rejig that curriculum. And then we have to also work together to train community healthcare. You know, like they say, primary care, they really have these structures. You have the community community development and the village development committees that you trained. And you have the community health extension workers that should not only be in the facility, they are supposed to be in the community, and they are supposed to take geriatric care to the homes of older people. It's done, and that's what we are working to do. So now we have home geriatric care, where the extension workers are now trained in geriatric care. And I want to tell you that what we are opening up here is going to create a lot of employment. Let's look at that angle. It's going to create a lot of employment. Look at our youths in this community. So we train, youth in this community, older persons who have the vigor and are willing to continue to engage in this community, so that when they're approaching older people, they're approaching them in their language. So we're going to open up to the interior and then make sure that we integrate the proper education, the proper care literacy, proper assessment, and then the environment. So you create a unit. There's nothing wrong in creating a unit that is age friendly. We retrain them, the attitude to older people, to lessen on the prejudices and the stereotypes, and to see that they are deserving to continue to live, and then the assets that they are when they continue to live. So
Okay, thank you, DJ. Dr. Chris
Yes, ma'am.
Lemwa, you've listened to the DJ. It's a whole lot of responsibilities and, of course, financial commitment involved in this new venture. But you have already indicated that you have the structure, and I'm wondering, what have you been doing with this structure ab initio? And do we have a place for the care of the elderly currently in this primary tier of healthcare?
Yes, thank you very much. Yeah, if you look at our manuals and our brochures and our guidelines, primary health care guidelines, and of course the components of primary health care for the elderly, that geriatrics, care for the elderly, are clearly there. But before now, maybe there's not enough attention, orientation of the healthcare workers towards that. That's an area, that's a gap, that's an area we need to breach and cover up. We need to do quick reorientation of that, of the nurses, the health workers at that level, to make sure that they buy in, they know that this is part of their responsibility, and our chief executive is not playing with that, so you could see if, I don't know whether you were part of our PhD summit recently. Yes. That is part of the packaging, PhD, to meet the stuff is meant for, and to give the quality services that people deserve. And of course, to have all this, make it all inclusive, including making sure the infrastructure are worthwhile, making sure that the behavioral, that all those functions, preventive, promotive, and curative, and rehabilitative functions of the primary care centers are met. So those are some of the packages we have, and we have re-echoed recently during the last summit. That's what we mean by reimagining PSC. Yes, and a PSC that can meet the sort, that can serve the people, over there, whether we're there or not. I mean, the level of health workers there should be properly oriented to know that yes, this elderly person should be cared for. It's not only, like she said earlier, it's not only for mother and child. Though we emphasize a lot because of the heavy burden of maternal and child health in the country. Looking at the statistics, that's why our ED declared, and of course the Federal Ministry of Health declared that threat as an emergency. And one thing I know I've seen with the agency and with our leadership is whatever he wants to do, he does it well. And in as much as he's tuned to this, with the emerging PSC, we'll be able to address the issues, bridge the gaps as it exists now. But we really know that that's an area we need to really work on.
Okay, Dr. Lebuwa, thank you. You raised the issue of the recent summit on the primary healthcare system. And we also, some weeks ago, had a conversation around the outcomes of that summit, where there seemed to have been a lot of accent or focus on the child and maternal care at that level. But we're then told that, well, of course, there will be other elements that will be thrown. And I want Dr. Tukor Ismail to also speak to this aspect. The summit that took place recently in Abuja, did it factor in geriatric care? Was this MOU part of the conclusions of that summit? And if so, how does it square with the outcomes going forward?
Yeah, thank you very much. It's really aligned with the outcome of our meeting, because like I've told you earlier, this has been in the National Strategic Development Plan. And so immediately there are some key activities that we are expected to implement at the level of the state, LGAs, wards, and even settlement levels. These are activities that are meant to ensure and strengthen institutional capacity of our health workers to deliver these services. For example, we are aligning with our tertiary institutions to ensure that the curriculum that we are having now factored in clearly the geriatric care in the training of our staff. Our staff that are going to graduate and comes out to start implementing, and also establishment of geriatric units at the state primary health care and also at the local government and all levels of it. And also he made mention of the plan to give a refresher training of the existing health workers at that level. We also make sure that we extend and leverage on the existing data repository that we are having, that's the DHIS, to collect all data relating to geriatric health and also the services that are being rendered. And also at community level, we have array of structures like the traditional and the Emirate Health Council, the Ward Development Committees, the community engagement structures and programs, and also the CHIPS program, which is had been rolled out in many states, including Zamfara State. These are all avenues to integrate the geriatric care. And basically at primary health care level, what we intend to attain is to make sure that we maintain the functional ability of those older people by ensuring that the intrinsic capacity is being maintained. And we all know that the intrinsic capacity is all about the physical and mental abilities of those people, talking about their ability I mean, there are musculoskeletal related issues which has been reeled out, talking about the osteoarthritis and others, heart diseases, diabetes, stroke, and chronic respiratory related issues. And also maintaining those intrinsic care services will prevent them from declining to become dependents for life dependency, where there is a lot of needs. So the basic services we are going to ensure that is being provided are the ones that are going to take care of the basic issues of ensuring that they are able to move around, their visual impairments have been identified. If at that level they can be managed, fine. If they cannot be managed, they should ensure referral to the next levels, and also to ensure their hearing loss is not there, that their cognitive impairment, the issues relating to psychological issues, depression, and others. So these are the issues that we try to make sure that at facility level are being inculcated into the practice of our healthcare delivery service providers. While at the community level, we work with their caregivers to ensure that geriatric syndromes like urinary incontinence, fecal incontinence, and other risk of falls and things, we create awareness across them to be able to identify and report those cases so that these aspects are being taken care of. So these are some of the immediate and long-term plans that the state primary health care, in collaboration with the national and with the structures we are having, are trying to ensure that we implement in our centers. Thank you.
Tukor Ismail, thank you very much for your response. I mean, what you have said is velvety, is soothing to the ears. These are plans, obviously, that could materialize. But what is the reality? Let's face it. For many years now, we've been struggling to revitalize our primary healthcare system. And after the Olukoye Ransom Kuti years, this is the first time that serious attention is being paid to primary healthcare. Do we have the capacity to revitalize our primary healthcare? Primary healthcare centers across many locations in the country are in a derelict state. And that's where you want to also take old people to?
Like you rightly said, recently, the drive that we are having to revitalize it, it's what gives that impetus. Because as a country, I think it has long been held wrongly in terms of expenditures. Because rather than spending our resources on basically preventing, well, we are majorly spending our funds on major curative sites. Because if you look at the current funds that are being disbursed to secondary and tertiary healthcare delivery services, if just 50% of that funds are being given to primary healthcare, you see the wonders that is going to create, because that is where the preventive aspect is being taken care of. And I've seen that in the recent summit, where clearly costed plans are being made, and there are avenues now that are being developed in a society.
All right, Dr. Tukor Ismail, we hope that connection with you will be smooth. I do hope so when we return to you. Thank you for your contribution. I bring my question back to the DG, NSCC. Yes, geriatric care, if you consider the functional health needs and other social needs, can be quite expensive. It's good, to mainstream it in the primary health care. But again, I'm wondering, just to tee up from Kingsley's question, I'm wondering, the primary health care as it is already choked up with responsibilities and, things it has to do, responsibilities has to meet to the people. in terms of providing for maternal care, child care, HIV, and other needs. And I'm just wondering, shouldn't we be looking at alleviating cost of, Medicare for this group of persons, rather than, finding a way of mainstreaming into the primary health care and choking up the system? I don't know.
Yeah, I'm very happy that you brought that question. And that gives me the opportunity to, talk about the approach of the National Senior Citizen Center to, program designing, implementation for the outcomes that we want to see for our older persons. One strategy is to mainstream, identify all these agencies that have programs and services and budget lines that by right, older persons should be included, which is part of primary care, and to ensure that we mainstream them and work with them to know the appropriate programs and to get the outcomes. The other approach that we have is to create new opportunities and create new, envision, innovate. So what can we do from where we sit now, from the problems that we have seen, to bring new opportunities, new partnerships, and new collaborations? So when we talk about primary care with the Primary Healthcare Development Agency, we're also talking about new opportunities that we will work with their structures, because you can't deny, the primary healthcare, they have the structures. We are just 10 months old. So we can't go creating structures. We don't have a budget for that. So yes, they have systems and policies and processes and structures already in place that go as far as the interior that we want to go. So we partner with them. But what new opportunities can we bring? For instance, we had to build senior centers. We had to also deal in promotional care and preventive care. That one does not need diagnosis, and you say, we are not clinicians, but that we can do, to determine social determinants of this ill health and to ensure that we guide them to prevent. So that one we would do. These are the new opportunities, creating, structures on ground. And how are we going to do that? We are bringing in private sector. We want to bring it. There are many people out there who have mothers and fathers who, like you and I, have been like, so what can I do because of them? How can I alleviate this burden? So we are attracting the network of support for older persons in all of the new programs, because we are creating very innovative programs, from health to income generation, to work schemes, even for grandmothers. We are creating, new innovations in recreation and sports, and government cannot do it alone, so we are bringing the private sector.
Health care. I'd like you to tell us, what outcomes are you envisaging from this mainstreaming? And then how do you hope to address the issue of funding, healthcare for geriatrics?
The outcome that I'm envisaging from the mainstream is, number one, like they have all said, there already exists some strategic framework for elderly care that is now being reactivated. And being reactivated means that we now, as NSCC, will have an input in that, bringing all the expert group, the stakeholders that we are working in. And then what we expect is also capacity building. Already they have staff on ground that do not have probably don't have the right attitude, don't understand it. I'm coming. For those on ground, they can be trained. For those on ground, yes, they have some staff on ground.
We have staff.
They have.
But what we're talking about, maybe you're looking at the midwives, which were maybe doctors at those areas, which were exploiting a lot of strategies.
Are you going to be multitasking your staff already on ground?
We are already
I
doing
think
that.
What you're looking at, when you look at, for instance, for takeoff and for starters, you look at the entire country, Nigeria, with 206 million persons. And then you look at now, population of older persons is 14.8. And by the recent survey by MBS again, you're putting it at 16 million now. So what we want to do is to take some pilots, across the geopolitical zones. And when we take some pilots and we can create this primary healthcare center that is age-friendly, that has unit for geriatric care, and they have trained, and then integrate it and loop older persons into the community. So we have a model. And when we have that model across, then we can bring in private sector. So you in your community, you have your, philanthropists in your community. These are your mothers and your fathers. Can you replicate this in this community? We really intend to go full throat partnership with the private sector. So if you can see this model and can work in your community, it can work in your community.
Dr. Abakao, sorry, I'm jumping in. Let's also again be realistic about the CSR of the private sector. That's the corporate social responsibility. Sometimes they get fatigued by demands for philanthropy. I'm sure you must have heard of this. And the funding aspect of a program of this nature, some would say, is the bedrock, is the touchstone for its ultimate success. When you look at other jurisdictions, particularly in the advanced countries, where there is, for instance, no welfareism, or even where there is welfareism, it is not at old age that you start knocking at government's door to provide budgetary allocations for the care of old persons. While you are young, active, and working, that's when you start making your contribution.
Exactly.
So the old people who are, of course, now old, and hopefully and prayerfully God will grant them more years, and they pass away. Those who are coming, are they making their own contributions today for their own care at old age? Because government's budgetary capacity is limited. And the private sector's capacity for CSR is also not unlimited. So how do you therefore fund this? Because we're saying, for instance, get them into primary health care and so on and so forth. Will it just be a question of diagnostics? There could be medicines, there could be all of this. So how would the supply chain be? Or will it not be the same, the same old phenomenon of mere consulting clinics?
I think we should retract back to where we are today. Some months ago, we are not where we are today.
That's true.
And 10 months ago, the National Senior Citizen Center was not created. So we didn't have the legal framework and the policy framework. And there was no seat for us to sit and map these things as a matter of right, as a matter of inclusion. So now we are here, we have a technical working group. And now, of course, National Primary Healthcare Development Agency, as a matter of their own initiative, they are reimagining the primary care. And they are reimagining new models of primary care, which some time ago may not necessarily have included older people. But now older people now are in the mix with the memorandum of understanding signed. And then before now, maybe we should have just looked at the national. It's only the national government that is going to take part. Now we have executive secretary from the state talking. And that MOU has been signed by the national and by the states. And of course, health is on the concurrent list. So we are not looking at only a federal budget. We are looking at different states having a political commitment, which the National Senior Citizen Center, with the national consultative stakeholder engagement mechanism that we are putting in place in every state. We're bringing 9 categories of stakeholders across pension union, association of elders council, experts in aging in different fields, geriatrics, gerontology, social care, nursing, and we are bringing in private sector, we are bringing in research and data to form a consultative forum on aging in each state with 2 co-chairs and a steering committee. These are our foot soldiers in the states. So when we get into any state and we are talking about health and social care, we have people in the state that will engage in high level, advocacy to shift policy and ensure that older persons are not overlooked. And of course, we are engaging with the Nigerian Governors Forum. The Secretariat was part of this deliberation and they have signed that MOU. So the state is in. The executive secretaries are in. And of course, older persons themselves in the association and the Nigerian Union of Pensioners are in. Because this kind of framework has never existed. So it is everybody. So it's not just, looking at the federal government and looking at private sector. It is everybody, including the states themselves.
Okay, Hajia Jibrin, we've kept you for a while. We will return to you. We just want to, get some information, out from the DG and of course the National Primary Health Care. Dr. Elemuwa, what does this MOU mandate your agency to do? What should begin to happen currently or immediately?
We are going to do a pilot, like she mentioned. We're going to do a pilot, develop models that can be referenced. That I will invite you to come and see, so that you see that this is a new NPA there, that we can make this happen. We invite you. You see it. That's what that mandate, that the MOU is signed. Yes, and it's in line with the mandate we have to care for health for all. I mean, all Nigerians, to make them healthier.
Open this book for us. Yes. When you say pilot, I'm sorry, Kingston, when you say pilot, let us have an understanding. Yes.
In each zone, in each state, we take, because we have already the federal government.
Structure.
Yes, the federal government and the state have, during the Dr. Adewole's government, as a minister, we mapped, we agreed that we're going to develop 10,000 PSCs, revitalize them. The present government and leadership has embraced that aggressively and is making it happen. It's not theoretical. When he was saying that it's not grammar, but this is practicals. That's why the imagined PSC, that's why our leadership say no. That the function, the mandate of the PSC must be exhaustive. Yes, and we must make it happen. We must be palpable, we must be visible, so that people will know that, yes, the services we are meant to give, we are giving it. We'll make sure that all those model PSCs are remodeled to make sure that they're places for care for the elderly. And we'll designate that, make it such that anybody can know that, as an elder, you can walk in there. It's no longer only for maternal and child and adolescent, but at least all-inclusive primary health care center. Some of us are still in the system, and to the glory of God, we are at that level where we can make things happen, where we can advise the ED, we can advise the management to say, please, this is what we signed, and then we need to follow it up. Yes, sir. Okay. We are signatories to that MOU.
All right. Thank you very much, Dr. Elemuwa and the other guests. It's not a question of being cynical. It's just some reality check, Claire. Because sometimes we've heard and seen attempts at getting things to work, and unfortunately they don't gain traction. And this is a very important subject matter we are dealing with.
Right, welcome back. We're still discussing caring for our senior citizens. I'd like to bring in Hajia Hawa Umar Jibrin into our conversation. Of course, she has a home, Paul's Old People's Home. Hajia, share with us. I know you do take, our senior citizens, for some medical care. What has been your experience? What is the behavior, and what do you expect from this new collabo between the NSCC and the National Primary Health Care Development Agency?
Yeah, our general hospitals across the country, they are not elderly friendly. That's number one. You go to the hospital with an elderly person, sometimes the elderly person is standing because there are no seats to sit and wait for the doctor, and there are no specialized doctors for them. So they queue up with every other person. And the elderly person is not the kind of person that is subject to that kind of treatment. You take an elderly person, you are expected to give that elderly person a seat while the doctor calls him or her. But in the hospitals, you don't get that. And you find that you come with an elderly person that cannot walk properly. There is no walking aid, no wheelchair. You are supposed to, lift the person, or maybe when you are coming, you get some people to come with you so that you can lift the person, take the person to where he or she's supposed to sit, which is not good enough. Because I expect in the hospital you have wheelchairs. As soon as you bring in somebody who cannot help himself or herself, you wheel the person to wherever. But you go to a lot of hospitals and you find that maybe they have 1 or 2 functional wheelchairs, and you have to queue for even the wheelchair to come, or else you have to be the one to take your patient to wherever. And the doctors are not enough. The doctors are not enough. Some of them, they are not really, you see general practitioners. Like you have an elderly person that has arthritis. Ordinarily, you should see
orthopedics.
yeah, exactly. But when you get there, they tell you, oh, he only comes on Mondays, Wednesday, or Friday. Therefore, if you have somebody who is in pain, you just have to wait for those days before you can see the doctor. And their drugs are not subsidized. Like some of us that operate in an NGO, we buy drugs for them, but we cannot continue to buy drugs for them all their lives, because some of their people are really, really very poor. They have nothing. They just have what to eat. They just feed themselves. And the elderly people don't even get the right nutrition. Because when you say somebody has diabetes, and you give the person rice, you give the person yam, you give the person all the carbohydrate, you don't expect that person to get well. But that is all they can afford. Therefore, nutrition should be added to what we will get from the National Senior Citizen Center, so that when you have people that are on special diet, they could maybe find a way to go around it and provide for them what they would, if they really want them to live and live well until the end of their time. Yeah. And doctors too, maybe there should be a section in the hospital where if an elderly person gets there, that person should go to the section where elderly people are seen, so that the comfort will be there until the doctor sees him or her. But if you are telling every person who goes to the hospital to queue up, then you are subjecting them to more pain and subjecting them to what we don't want, that is suffering, because they deserve to be taken care of properly. And if they go to the pharmacy, like their routine drugs for hypertension, diabetes, I think they should even make it free for them, because some of them are just trying to maintain. It doesn't cure. It's not curative. You just give them to take every day so that they maintain that level of whatever they have instead of making it worse. And we provide for them, but we too get it as a donation from pharmaceuticals from USA and other countries. And we give them just to sustain them. But when it really gets worse, it gets aggravated, we don't have any other means of taking care of them. And we need ambulances in strategic places. Elderly people who are sick cannot walk to the hospital. Elderly people who are in the rural areas do not have vehicles. So except you have ambulance where you can come, take them and bring them back. But I see most hospitals, maybe they have 1 or 2. And those ones are even meant for mortuary. Those who are in the mortuary, take them when they are dead or something like that. So you see that we have not really made any provision. I haven't seen one hospital that has made provision for an elderly person in this country, except the private hospitals. And the private hospitals are expensive.
Big time, big time. Ajia Hawa, thank you very much. Well, incidentally, some of the issues that we are raising this morning, they are in sync with what the Federal Ministry of Health has been pushing. For instance, the reinvigorated primary healthcare system, and then the ambulance system that Haja just spoke about. There is a pilot scheme for ambulance services, because those ones are very critical. We had the Honorable Minister of Health discuss that here with us, along with some other persons. So going forward, some of these things obviously will begin to gel. Dr. Tukur Ismail, once again, we return to you via Zoom in Zamfara. Again, there's a lot of enthusiasm from what has been said. MOU has been signed, the Governors Forum, they have keyed in, everybody is on board, state PHCs, everybody is on board. Look, as I said earlier, skepticism is part of the attribute of a journalist. From what we have seen, from what we have heard, state governments did not require this MOU to energize them to the reality of caring for old people, or even looking upscaling their primary healthcare centers. How is this going to work for old people? It said that you're going to bring in stakeholders, pensioners who are being owed by state governments, state pensioners who are crying on the streets, almost in state of destitution. And so somebody's going to ask himself, look, what is going to work? For many years, UBEC, the federal government launched UBEC, that's the Universal Basic Education Scheme or Commission, and said, look, 50% is what the federal government will put down. We have the 50%. Bring your own counterpart funding, and you collect everything. For many years, state governments were not doing anything, and the primary schools were in a derelict state. Is this narrative going to change even now with the professed dynamism with regard to geriatric care through the primary healthcare system?
Thank you very much. I can see the apprehension being expressed by virtually all of you. And if I could start by the submission of Hajia Hawa, where I can see she talked about the availability of health workforce. We all know that there's that constraint across the country, but I want her to appreciate the model that we are going to implement. At primary health care, we are not waiting, our own is to prevent their decline from their functional capacity and intrinsic capacity to dependency. It is when it gets to the level of that dependency that you see them being willed to the facilities or being rushed and things like that. But to address and allay the fears of the constraint in terms of health workforce, there's a tax shifting policy that gives the other cadres, not necessarily and mandatory, that only doctors should implement some services. You see, like most of the geriatric care, if you look at them, they are chronic diseases, let's say hypertension, diabetes, and musculoskeletal related arthritis and others. These are services that can be delivered at home, because our staff are being employed on the basis that 70% of the time is not.
Okay, well, I expressed this concern earlier on. Dr. Tukru Ismail, we're sorry about that once again. Hopefully, we'll probably get back to you before we, end our conversation. But let me bring in the DG. And DG, again, we're looking at the commitment of state governments. And I'm wondering, beyond the signing or buying in, which usually is lip service, and all that, what is the assurance? What other commitments have the governors or the state executives made to realizing this objective?
Well, I cannot speak for the governors or for the state, but I can speak for the National Senior Citizen Center and the structures we have put on ground, engagement mechanisms we have put on ground. That's where the National Union of Pensioners came in, and that's where Elders Councils came in. That's where experts in aging came in. That's where CSOs, FBOs, that's where all of them came in. And why is this structure very necessary? This structure up to the local government is necessary for us. Because for you to get these things going, you must have that political commitment that I can't speak to right now. But that we are putting structures in place to ensure high-level advocacy, continuous bombarding advocacy for the persons who need these services.
Is their commitment such that they can be held accountable?
Sure.
Of course, they can be held accountable. They will be held accountable. So that is before now. I want to. I keep taking you back. Before now, you didn't have a coordinating agency like the National Senior Citizen Center. So older persons' issues were thrown here and there haphazard, and nobody cared. Before now, other MDAs were doing things for other age category. Nobody cared to include older citizens. So for the first time, I will always thank this administration for giving us a policy and giving us a legal framework. It has never happened in Nigeria. So for the first time now, we are now putting state structures up to national consultative forum that we can speak to authority and that we can get them to do what they need to do. Right now, we just signed an MOU with National Primary Healthcare Development Agency. So now that takes me to other issues that my sister talked about. The unfriendly environment that older people find themselves, not only in the hospitals, like she said, but even in the banking sector, in the transportation sector, aviation sector. Why? Because there was no framework and there was no concerted, avenue to address these issues. Now, that is one of the cardinal priority areas of the National Senior Citizen Center. And firstly, is in our act. And secondly, when we had the presidential summit, first ever presidential summit, that was a presidential declaration that older persons should have a special ID card. And now we are working with NIMSI. There's a technical work and we've gone very far. Now that ID card is going to be taken off disaggregated numbers of older persons from the NIN. It's not going to be a different number. But from the NIN, there is a special functional card that NIMSI, in collaboration with NSS, is designing for older people. And that card is not for, just pinning it for nothing. It's for access to age-friendly services. And very soon, you're going to see us start our first town hall meeting, because we are bringing all the Nigerian Union of Pensioners, all the stakeholders, to sensitize them what this card means. And that all of us owe ourselves to go on high-level advocacy to get discounts. Aviation. Older persons need discounts. Railway transportation.
What is the age? From what age?
Older persons for the policy, for the national, that's what we are trying to reconcile, because the policy says 60 years, and the mandatory age for retirement for most is 60 years. But the National Senior Citizen Center Act says 70 years. So we are in between, and what I say,
the gap between 60 and 70 the gap between 60 and 70 is very wide.
What I even say is that if you go to the rural areas, somebody that is even 55 years or 60 years, because of accumulated disadvantages and poverty through the trajectory of life, that 60-year-old person is looking like an 80-year-old person. Mm-hmm. And these are the people that need these services. So that's what we are discussing, Yeah, so anyway,
we'll work on that.
So there is this card, and now we are going to go on campaigns to all the, sectors. We have mapped out sectors: the banking, financial sector, the health and health services sector, the transport and aviation sector, to make them know it behoves on them to ensure that the environment is age-friendly, services are age-friendly, attitudes are age-friendly, that older persons deserve priority treatment, dignified treatment, So that's what and very soon we are going to be backed by the law. The policy, yes, and everything is in place. The Senior Citizen Act is in place, but the Older Persons' Rights and Privileges Bill is now before the President for accent. So it's a good, I think very soon we are going to realize that in Nigeria, the Age Watch Index is changing. The attitudes are changing, services are changing because of the creation of the National Senior Citizen.
Not that they are changing.
They are already changing. The narratives are already changing. That's why we are sitting here. It's already changing.
Will change. Well, you were praising the current administration for the enunciation of the policy and the signing into law of the bill. You didn't praise the NTA. For grounding these issues, and particularly on Good Morning Nigeria, where we have had you on a number of occasions. There is also a distinguished senator who is also been our guest. We had a geriatric expert at some point from University of Abuja by hospital. We've put these issues on the front burner. We've discussed with pensioners on a number of occasions. At some point, pensioners who were being owed, said that they were having issues with the Ministry of Finance and that they gave them an ultimatum. If they didn't pay them, they were going to take steps. We were asking them on that occasion, what are the steps? Are you going to go the native way or otherwise?
So Kingsley, give me an opportunity to say this. I should be the one saying this. And I said it earlier. I think the cameras were not on. That there is no way we talk about where we have gotten to today in aging without NTA.
That's good.
I was on the other side as an advocate, and I know how many times.
How many times
NTA has been the driver. NTA has been the lens. NTA has magnified the voices of advocates, the voices of older people, and we are sitting here still NTA. So I applaud you.
All right, Kingsley.
All right. Well, it's basically, this is a continuing conversation. Sometimes we are too much in a rush to achieve results, but that reality check is very important because we know that part of the major challenge that we have faced in the country in recent decades relates to lifting a plan from the paper to implementation and then you see results. And that's why a number of these issues have been raised. So on that note, I would like to thank all our guests who've been with us on the conversation this morning. Via Zoom, we had some disruptions. We had Dr. Tukur Ismail. Tukur Ismail is Executive Secretary of the Zamfara State Primary Healthcare Development Board. He's back there. Dr. Tukur Ismail, well, thanks a lot. We are seeing your face just as we were signing you off. And as you said, we will, of course, continue this conversation, several other aspects going forward. Ajia Hawa Omar Jibrin, founder of the POS Old People's Home here in the nation's capital. I liked your explanation of why you chose the word pause. After working for several decades, there you pause. You pause. That's the way it is. Thanks a lot for your contribution. Dr. Chris Elemuwa, Acting Director, Community Health Services of the National Primary Healthcare Development Agency. Thank you for being our guest. Dr. Emme Omokaro, very passionate Director General of the National Senior Citizens Center. We appreciate your being with us.
Thank you so much.
And just take this one home because this act on senior citizens that says 70 years did not factor in the country's life expectancy. Otherwise, you would say 70 years.
So what is going to happen now after the MOU?
The service after the MOU, the technical working group goes into action. To the steps.
We have outlined next steps. This is one of the next steps. We're at least it has brought us here now to expose us for that. That if we don't do it, and I assure you that within few months or year now, a few months, we'll be able to showcase what the outcome of this conversation. Yes, sir.
All right, thank you very much. Let me again say a very big thank you to all our guests for today. It's been an interesting conversation, and we wish, of course, the NSCC and the National Primary Healthcare Development Agency the best of luck. Not forgetting Ajia, who, of course, will be a greater beneficiary of this MOU.
Not herself, it's our outfit, our NGO, and what she does.
And so that's how we end our program today. Good Morning Nigeria for this week also. We thank you as always for joining us. We do hope you'll be our guest on Monday when we bring you another interesting edition. On behalf of the GMN crew, I am Claire Adelabo Abdul Razak, wishing you a great weekend. Bye-bye.
And I'm Kingsley Osadola saying enjoy the rest of your day and do have a lovely weekend ahead.